and then again he will develop again second sickness will be there, and then that is because of the bacterial infections. So what is the stage of ischemia? Because the ischemia means there is a blood supply is reduced because of the inflammatory reaction. So then there will be irritation of the nose, then sneezing will be there, then there is a rawness, and then there is every chance for a frequent desire to clear the throat, and everything will be there, and then malaise. So because of the viremia, the patient will have weakness and then lethargy. So these are all the various stages of ischemia. Next is stage of hyperemia. So hyperemic stage means there is an increased blood supply to the nasal cavity, and then there is a profuse watery discharge will be there. Rhinorrhea, that is, it is not watery. It usually, because of the profuse serous secretions, it will appear as if it is a serous. Otherwise, it will be seromucinous usually. More of serous fluid, less of mucinous. So usually it will be there. So in these conditions, one may be confused with this CSF rhinorrhea. Watery rhinorrhea is always we have to suspect CSF rhinorrhea. So how to differentiate between these two things? One is by taking a kerchief and then make it to take the discharges from the nose and then allow it to dry it off. If it is a seromucinous, usually within a few hours, 1 or 2 hours, it will stiffen. Whereas if it is a CSF, it will not stiffen. Kerchief test. If it is a stiffening is there, means because of the presence of mucus and then starch there, glucose, so it will stiffen. Whereas in a CSF, where it is only mainly watery, the kerchief will not get stiffened. Then, because of the hyperemia and then congestion of the mucosa, all the nasal cavities will become narrow because of the congestion and the hyperemia of the hypertrophy of the. Because of the increased vascularity, there will be engorgement of the turbinates and also the septal mucosa, and then there will be a narrowing, and then there will be nasal obstruction. Wherever there is a nasal obstruction and inflammation is there, there will be loss of sense of smell will be there, and then the aeration of the sinuses will be impeded. Whenever there is a impediment, that is a derangement in the aeration of the sinuses, what will happen? The sinus ostia will get closed, and then that will result in vacuum headache. The patient will feel dull headache, and then whenever there is an infection is there, the constitutional symptoms like fever, malaise, and then thirsty. Because of all these things, the patient will have constitutional symptoms. And then on examination, you can see a congested nasal mucosa. And then secondary infection. So wherever the secondary infection sets in, what will you see? The patient will say he will have yellowish or greenish, depending upon the organism involved. The patient will have yellowish thick nasal discharge. Mucopus will be there, and then the patient will have fever, headache, body pains, they will be. And then because of the rhinitis going and then causing eustachian catarrh, and then resulting in atalgia, pain in the ear, and then congested nasal mucosa, and then the patient will have oral symptomatology like dull hearing, the decreased hearing, and then dull ache in the ear, and then blocked sensation in the ear. So it will take 6 to 10 days in uncomplicated cases. Otherwise, complications like sinusitis, pharyngitis, and then laryngitis, tracheobronchitis, pneumonitis. These are all the various things. If you don't attend to it, the resolution, if there is no secondary infection, resolution will take place in 6 to 10 days. Whereas if this is complicated by infection, it will result in these things: sinusitis, pharyngitis, laryngitis, and tracheobronchitis, pneumonitis, and then ASYM. If is not properly treated, there is a result in otitis media with effusion, with a constant blockade of the eustachian tube. So what is the treatment? First thing is one has to be given bed rest. And then hydration is one of the very, very important things in any infection, because then whenever there is infection is there, the toxins, endotoxins, that is the pyrogens and everything will accumulate in the body, and then they will cause the pain and all the inflammatory signs, the fever, body aches, and everything. So to drain all the toxins from the body, one has to take plenty of oral fluids. If the patient is ambulatory, oral fluids are very, very essential, and lukewarm fluids one has to take, not the cold ones. And then one has to take steam inhalation, always steam. The heat will act as a complete locally acting relief. It will decongestant and then will give a very good relief. And then you have to be systemic antihistaminics and then systemic decongestants. If there is a pain and everything, the fever is there and the body pain, analgesics and antipyretics. And then if there is a secondary infection you are suspecting, you can give antibiotics. If you don't suspect any secondary infection, don't ever go for any antibiotic. Otherwise, you will develop a antibiotic resistance. Always in a viral diseases, usually it will last for 7 to 10 days. First of all, you take all the precautions of taking bed rest, plenty of oral fluids, steam inhalations, and then if possible, if there is a discharge is there, you can give antihistaminics where they can reduce the nasal secretions, the decongestants. That they both are important. And there is a antibiotic fever and everything, because in a viral fevers also there will be fever and the body pain. So one has to take analgesics and antibiotics. Antibiotics only if you suspect any bacterial infection. Specific acute rhinitis is the diphtheria is the specific. That means you can identify. But isolated diphthetic rhinitis is very, very rare. Usually, it will be followed by faucial diphtheria. Faucial diphtheria is the commonest thing. But diphtheria, you know pretty well, it is caused by Corynebacterium diphtheria. And then usually in children, nowadays, again, we are seeing partial diphtheria. Along with that, the patient can have a primary affection of the nose is very, very rare. And then it is always secondary to partial diphtheria. So here, what will be the symptomatology? Here, compared to the other rhinitis, the specific to diphthetic rhinitis, the patient will have blood-stained watery rhinorrhea. That is blood-stained, and then serous discharge will be there from the nose. And then the patient will have, because of the constant discharge, the patient will have vestibulitis. And then the patient will have nasal obstruction because of the congestion or formation of a membrane. And then sometimes, usually it will be irritating. So the children usually they pick the nose and then they lead to bleeding from the nose. That is epistaxis. So on examination, what will you see is a great vegetative white membrane of the nasal cavity, that is over the either on the septum or the turbinates of the floor. And then it will be, in this case, usually it is very, very difficult to remove. So whenever you try to remove the membrane from the nose, there is so it will bleed and then it will leave a raw area on the nasal mucosa and then will have a very unpleasant to the patient as well as the treating doctor. So constitutions are usually not very prominent, but we have to see if the membrane is there, one has to suspect and then take a swab and then send it for culture or microscopic examination for Corynebacteria. So an exam also you have to examine the throat whether it is secondary to, usually it is secondary to faucial diphtheria. So one has to examine the fauces and the C and the tonsil when whether there is a grayish white patch is there or not, depending upon that. So what is the next thing is swab. So this bacteria can be seen. So we will discuss in detail about the Corynebacterium is the faucial diphtheria and the throat class. And then all the relevant investigations, whatever we do there for the partial investigation, we have to go for them. And then treatment is always as a partial diphtheria only. First of all, the patient has to be isolated and hospitalized. We are having a isolation hospital is there. It is a infectious diseases wards are there, GHCCD, and then one has to start with the penicillin diphtheria antitoxin, and then antitoxin, that how to calculate the dose, and then depending upon that, you have to involvement of the sites. With the involvement of the sites, one has to increase the dose of the antitoxin. Usually, it will be cured. Usually, whenever you take all these precautions, usually it will be cured. Now it is the chronic rhinitis is a simple chronic rhinitis. So in a simple rhinitis, so usually the patient will have recurrent attacks of acute rhinitis. Usually, whatever the predisposing factors, usually underlying either deviated nasal septum or any polyp is there, or sometimes the patient is having a polyps, or the patient is having a underlying sinusitis. Smokers, either active as well as passive smokers, both will have this chronic simple. And then alcoholism, pollution, dust, and smoke, then overuse of nasal drops, rhinitis medicamentosa, or a vasomotor rhinitis. These are all the various predisposing factors which can lead to chronic simple rhinitis. That means the patient will have a nagging every time, recurrent attacks of acute rhinitis. Again, you will come down, and again for some days you will be free. Again, you will be having a symptomatology. So what it has to be seen is, first of all, the predisposing factors, the causative factors have to be removed. So what are the symptomatology? Nasal discharge, usually mucopurulent. And then nasal obstruction will be there, mild headaches will be there, and then patient will have loss of sense of smell. Because whenever there is any obstruction and then there is a mucosal inflammation, along with the nasal mucosal inflammation, olfactory area also gets inflamed. And also there is the nerve endings will not work, or otherwise because of the obstruction, the smell bearing atoms will not reach the area of the olfaction. Then the patient will have loss of sense of smell. Whenever there is a loss of sense of smell is there, the patient will have loss of taste, or altered taste will be there. So the patients will be telling, sir, so I'm not able to relish the flavor of the food. So these are all the, whenever we are having any acute rhinitis or anything like that, so we will be having a change, altered taste, everything. So these are all the symptomatology and things which can happen. And then, so an examination, hyperemic mucosa with edema will be there. And then there will be an examination of post-nasal space, thick mucus, viscid mucopurulent nasal secretions, and then post-nasally drip will be there. That means mucopus will be dribbling out of the post-nasal space to the oral cavity, causing pharyngitis, chronic pharyngitis. If you see the throat will have a granular chronic pharyngitis. So what you have to do, then you have to nasal douches. So alkaline solution has to be prepared, and then nasal douching should be done. So all the predisposing factors, the vasomotor rhinitis or anything, if the patient is having a deviated nasal septum, you have to correct the deviated nasal septum. If the patient is having sinusitis, you have to treat the sinus infection. If the smokers are there, one has to tell them that you have to quit the smoking, or people who are passive smokers, so they should ask the patients to leave the person who are smoking nearby. And then alcohol and smoking should be avoided. These are all the things, precautions one has to take for treating a thing. Apart from that, you have to give, if there is an acute simple rhinitis, if you think that the bacterial infection is there, then you have to give antibiotic and decongestant, systemic as well as local. Can anybody tell one local decongestant? Can anyone say that? Name one local decongestant. Pseudoephedrine is a systemic. Xylometazoline is correct. Who's Aishwarya? K. Aishwarya, correct. This is Muhammad Hasil. You are telling pseudoephedrine usually is a oxymetazoline, xylometazoline, nefazoline. These are all locally acting thing. Pseudoephedrine and the ephedrine, these are all systemics. Okay. Tablets forms are available. So chronic hypertrophic rhinitis. There is another thing is hypertrophic rhinitis is there. Simple rhinitis, it can be thickening of the mucosa and submucosa, and then seromucosa glands are enlarged, and then periosteum is also thickening will be there, and then bone will be also sclerosed bone. This is a chronic hypertrophic rhinitis. Here you will have a, see, if you see there is a hypertrophic mucosa, and then this is acute rhinitis, it will be written, but usually hypertrophy will be there. For this chronic hypertrophic rhinitis, and so recurrent acute rhinitis can lead to chronic hypertrophic rhinitis. And then these are all the whatever the predisposing for that, it can be, everything can be the same. That is vasomotor rhinitis, allergic rhinitis, pollution, dust, smoke, smoking, alcoholism, overuse of nasal drops, vitamin deficiencies, polyps, sinusitis, DNS, tonsillitis. These are all the various things because continuously tonsillitis means they continuously supply infection to the nose, the surrounding areas, and then the patient will have chronic hypertrophic rhinitis. Symptomatology will be nasal obstruction due to hypertrophy of the turbinate, and then nasal discharge, thick and viscid nasal discharge will be there, and then patient will have loss of sense of smell, and then headache will be there, pain in the ear, and then sore throat. These are all the common things which a patient can have with the acute and chronic simple rhinitis. And then sinusitis, hypertrophy of the inferior turbinate will be there, hypertrophy of the nasal mucosa, and the mucosa can be congested or pale. Pale means usually we think of allergy, but in a chronically inflamed conditions, mucosa can be highly congested or it can be a pale. Posterior rhinoscopy, mulberry-like appearance of the posterior ends of the turbinates will be there. Anterior rhinoscopy, you can see the string sign. The string sign is nothing but there is a mucosal thread between the lateral wall and the septum. So the septum, there is a thing that indicates is a chronic rhinitis. So you have to differentiate between a hypertrophied inferior turbinate and a polyp. Sometimes they may pose a confusion for a clinician. So what has to be done? One has to probe. So if you probe the test, so in my clinical examination, I had told you one thing is a probe. Probe test, by doing a probe test, what are the things you can learn? One thing is site of origin. Next is sensitivity. Next is consistency, and then mobility, and then bleeding and touch or not. So these are all the various things you can know by doing a probe test. So here you do a probe test, you can see the turbinate is attached to the lateral wall of the nose, whereas polyps usually comes from, they also come from lateral wall, but somewhat from above, superolaterally. Okay, because the ethmoid labyrinth or the maxillary sinus ostium they will come, and then the polyps are insensitive to touch, whereas turbinate is sensitive to touch. And then mobility. The Polyps are very much mobile, whereas turbinate is not that much mobile, because when there is a bogey will be there, soft, but it will be painful, and also it is completely attached to the lateral wall. And then by doing a topical decongestant, the turbinates. Can you tell me one topical decongestant or a local decongestant that is like a oxymetazoline, xylometazoline? Okay, these things. Or Edeline also. With the xylocaine with Edeline, if you dip the cotton wool and then keep it in the nasal cavity, then wait for 5 to 10 minutes, usually it will shrink. The turbinate will shrink, whereas polyps will not shrink. That is the other clinical examination where you can differentiate between a polyp and a turbinate. The treatment of the chronic simple rhinitis or chronic hypertrophic rhinitis is mainly removal or treatment of the predisposing factor. So, first of all, you have to understand why it is coming. And then the main thing is, unless otherwise you treat the predisposing factor, cause the chronic simple rhinitis or chronic hypertrophic rhinitis cannot be cured. And then you can give antihistaminics, decongestants, systemic as well as local drops. Surgical management is by reduction of the turbinate. If there is any turbinate hypertrophy is there, we can reduce the turbinate by doing a submucosal diathermy or cryo, laser, or surface cauterization, or a partial turbinectomy, which is now being abandoned most of the time. But nowadays we are all doing a turbinoplasty, that is reduction turbinoplasty. We can reduce the size of the turbinate. There are so many methods are there. We can reduce the turbinate. And then what is rhinitis sicca? These are all the various questions. You will get a 2 marks question. Rhinitis sicca, there is a drying and crusting affecting of the anterior portion of the nasal cavity. So only the anterior portion of the nasal cavity, which can be seen by anterior rhinoscopy, there will be drying and crusting. And then sometimes if there is crusting is so high, so if the patient will have sometimes septal perforations also. Where will you see? So it is a mostly occupational hazard. So those person who are working in dry conditions, like in any furnaces, hot furnaces, dry conditions, dobies, dusty environment, rubber factories, workers working in a rubber factory, the furnace workers, bottle blowers, these are all the things which they are the people who are commonly involved. Then they will have that drying of the nasal mucosa because of the hot atmospheric air. And then there will be drying of the mucosa and then crust formation in the nose. So nasal obstruction due to crusting, and then irritation, because whenever there is a crust is there, underlying irritation, infection, and then irritation will be there. And then every time, whenever there is unknowingly and then involuntarily, we try to put our finger or something there in the nose and then try to remove the crust, so that whenever you remove the crust, there will be a raw area will be there, and then they can lead to bleeding from the nose. So on examination, there is a dry red mucosa with crust and the ulcerations will be there. Involvement of the only anterior part. In the posterior endoscopy and the endoscopical, if you see posteriorly, everything will be normal. Sometimes you can see a septal perforation. But here, the difference here, one has to see wherever there is a septum, there is a crust is there, we tend to go for atrophic rhinitis. Here, atrophic rhinitis, the patient will emit a very bad odor. That means fetid odor. The surrounding people will have a very bad odor. Whereas in rhinitis sicca, that is a dry rhinitis, the patient will never emit any bad odor, or he himself also can perceive smells. Whereas in atrophic rhinitis, the patient will lose the smell. So that is known as merciful anosmia. That means for the patient, he may not be knowing, but for the people who are living with them, they will feel that stenchy feel. Okay. The next we'll talk about the interference. Post rhinoscopy, usually normal mucosa, and then no crusting, no drying can be seen. Treatment is alkaline douches, emollients, because any softening solution, any like glycerin or liquid paraffin or Vaseline has to be applied so that there will be softening of the crusts, and then you can remove easily without any raw area. And then only thing what you have to advise them is either they have to take a protective devices to prevent from the dry heat, or they have to change their job of environment, change the environment or job, because usually those who do certain jobs, they are traditionally they do their jobs, they cannot leave, but they have to take adequate precautions before entering that area. There are certain protective masks are there, then they can use them. Industrial masks are there, so they have to use if they under the employee state insurance and the labor laws, each and every person who is working with them are eligible for that on the protective gear. And then next is rhinitis caseosa. This is previously known as cholesteatoma of the nose, because what is the cholesteatoma? Usually you see in the ear. We will not see in the nose. Nowadays, there is no more a cholesteatoma of the nose. It is only a rhinitis caseosa, as a chronic rhinitis, where here there is a accumulation of caseous material, cheesy material in the nasal cavity, because it is so thick, the patient cannot sneeze it out. It will not come out normally, but the patient will have that bad cacosmia. That means the patient will himself will feel that he is having a very bad smell from him. So here it is usually unresolved chronic sinusitis. Is a fungal rhinosinusitis or bacterial rhinosinusitis, where because of the loss of the ciliary motility, there is a this pus will not be drained out, and then they accumulate there and then result in cheesy material. Because there is accumulation and then there is a widening of the nasal cavity, it is known as cholesteatoma of the nose. Otherwise, it is a rhinitis caseosa. The exact etiology is not known. It is thought to be failure of the resolution of the sinusitis. So here the inspissated contents of the sinuses, they come out like this, and then they emit that fetid odor, inflammation of the granulation of the lining mucosa. Sometimes there will be bony erosion, because here is a bony erosion is there. So the term cholesteatoma is coined. Nasal obstruction, bad smell to the patient, or sometimes the patient may not have the smell himself. Patient will have thick viscid rhinorrhea, and then headache, because this inspissated pus is there. Always there will be headache will be there because of the complete fullness in the sinus, can also, as well as vacuum headache. Complete fullness of the sinus also will create headache by irritating the nerve endings of the sinus mucosa. So thick cheesy, an examination of the anterior rhinoscopy, you can see thick cheesy caseous material in the nasal cavity, bad odor will be there. And then if you take anything, maxillary sinuses also is tender. And then if you take an X-ray, you can see a very hazy maxillary sinuses with a nasal unilateral, usually. Bilaterality is rarity. Bilateral sometimes you can see also, but usually it will be seen unilaterally. So here what you have to do is, the medical management is very, very difficult here. You cannot evacuate the CG material. What has to be done is, you have to take the endoscopic sinus surgery, then you have to completely widen the maxillary ostium, then completely evacuate the pus. Patient will be good. In a recurrent cases where the sinus mucosa lost its ciliary movement, one thing is Cordwell operation. Then any extensive disease. Usually nowadays we are avoiding this Cordwell operation. In here is a radical one where we exenterate completely the mucosa of the sinus mucosa, that is the maxillary sinus. Coming to the atrophic rhinitis. Atrophic rhinitis is a chronic inflammatory disease which is characterized by a triad of progressive atrophy of the mucous membrane of the nasal cavity, that is the turbinate and the nasal mucosa, excessive crusting of the nose, and then small foul smell emanating from the nose. These are the three characteristic features that is known as triad. It is in 1857 or 56. So Bernard Friedman is the man who coined this, identified this trade, and then so after him, some people say it is a Bernard's trade or a Friedman's trade. The progressive atrophy of the mucous membrane and turbinate, excessive crusting of the nose, or smell emanating from the nasal cavity, that is known as Zena. So geographical distribution, usually it is commonly not seen in well-developed countries. It is a disease of developed or underdeveloped countries. Usually in India, it is 0.7 to 0.9% of the cases, ENT cases, and 10% of the nasal diseases will have this atrophic rhinitis. Nowadays, we are seeing a lesser thing. The thing is because of the increase in nutrition or anything, usually because mostly we are seeing these conditions in very poor and patients who are living in slums, the unhygienic areas. These are the areas where we will see this atrophic rhinitis. Sometimes hereditary also is implicated. So this is the geographical distribution. It can be two types. One is a primary, where the etiology, if you don't know any etiology, we call it as a primary. If you know an etiology, it is a secondary. So it is secondary to so many things. Primary atrophic rhinitis, exact etiology is unknown. So here, all these hereditary, racial factors, developmental factors, and then endocrinal factors, all these things will come. So hereditary factors, what is autosomal Mendelian inheritance pattern? So here, in 20% cases of a single family suffered, so they say it is hereditary transmitted. Race, commonly in yellow Latin races, that is in Mongoloid race and then Latin Americans, usually it is seen in a poor pneumatization of the maxillary sinus, and then shortening of the nasal anteroposterior length of nasal cavity is observed in certain cases. So they say it is a developmental abnormality. And then commonly age, it's from 15 to 40 years. Females are more endocrine disturbance whenever, because occurrence of the girls during puberty and then become worse during menstruation, menopause, or pregnancy. So one has thought that it is because of the endocrine. So there is an improvement with estrogen therapy. So that's why it's endocrine dependent. So this is one of the theories. And then nutritional, that is iron deficiency and vitamin deficiencies also can cause the atrophic rhinitis. So what is the infection? So in all types of primary cleansing, these are all various bacteria. Klebsiella ozina, Coccobacillus fetidis ozine, Bacillus mucosus, Bacillus influenza, Proteus vulgaris, diphtheroids, and then E. coli. These are all the things which are isolated in atrophic rhinitis patients. So these are all the etiological factors, or sometimes you can say they can be a commensals in the atrophic rhinitis patients. Autonomic imbalance is the autonomic imbalance because our nose is always tergiscence, nasal tergiscence, and detergitance, that is a congestion and decongestion, are being by the sympathetic and then parasympathetic overactivity, parasympathetic activities. If they are in balance, usually we don't feel anything. So autonomic imbalance resulting in excessive vasoconstriction, that is known as reflex sympathetic dystrophy. RSDS, this is one condition where there will be constant vasoconstriction. Wherever there is a vasoconstriction is there, the blood supply will be reduced there, and then there is a, just like any akin to regional osteoporosis, the nasal mucosa, the osteocalcium content will be reduced, and then there will be reduction in the size of the bones underlying, and then mucosa also will get atrophied, and then also the submucosa also get atrophied. Here, and also reflects sympathetic dystrophy, where hyperactivity, there is a congestion. Suddenly, the sympathetic activity will come lowered, and then there is a vasodilatation, and then hyperemic decalcification of the turbinate. Sympathetic or hyperactivity or inactivity both can cause problem there. So another thing is autoimmune. Cellular immunity studies show altered cellular activity are less tolerant to nasal tissues. So that means there is some autoimmune disorder along with malnutrition, immunodeficiency, virus infections, because all these destructive autoimmune process, the release of antigens, antibody. So this antigen antibody, which will take place at the nasal mucosal level, and then there it can cause around the vasculitis, because the increased IgM levels will be there, and then they result in vasculitis. So whenever you have vasculitis, there will be endarteritis and periarteritis. So whenever there is a periarteritis and endarteritis is there, what will happen? There will be occlusion of the vessels, and then there is a reduced blood supply to the local area. And then there is, because if you don't understand a disease, we implicate multifactorial. So all these factors can come together and then can produce a atrophic rhinitis. That means separate multiple factors work simultaneously and cause this problem. So what is the pathology in the local? If you take a biopsy from the nasal mucosa, what will happen? Mucous membrane will be atrophied or metaplasia or cuboidal. Normally, what is the nasal mucosa? What is the normal nasal mucosa? Can anyone tell me? Ciliated pseudostratified columnar epithelium. Okay, pseudostratified. Okay. So when this is going to pseudostratified, so metaplastic cuboidal to squamous epithelium, because cilia will be lost, and then it will become a stratified squamous epithelium. Because of the atrophy of the cilia, and seromucinous glands also will come down. So secretions also will become very, very, very minimal, less, and then they become very viscid. What is happening in the blood vessels? Atrophy of the venous sinusoids, and then arteries, obliterative endarteritis and periarteritis. Whenever the arteries are surrounding endarteritis and then periarteritis, the vessels will become very narrowed, and then there will be loss of cilia and then loss of stratification, the pseudostratification, and then this a squamous metaplasia will take place. This is the local pathology. And then there is a degeneration of the nerve endings. So whenever the nerve, what is the nerve supply to the nose? Hello? What is the nerve supply? Nerve supply. Somatic, autonomic, and special sensory. There are three types of nerve supply to the nose. What is the somatic nerve supply, please? Hello? Maxillary division of the trigeminal nerve. Okay. So whenever the nerve endings are destroyed, what will happen? Usually, even though in this condition, these are because of the nerve endings degeneration, the thing is The patient will never feel that the patient is having a normal breath. Even though the air entry is normal, the patient will say, I'm not able to breathe through the nose. That means I'm not feeling that I'm breathing. Here, turbinate bones are atrophied because of the sympathetic dystrophy syndrome. So turbinate bones gets atrophied. Olfactory nerve endings also gets atrophied, and then the patient will have loss of sense of smell. And developmental, because these people, this can be seen in adolescents, in young adults and girls. So where the paranasal sinus developments will take place at the time, they may get arrested. Then the sinuses can be very small, and then loss of ciliary action because of the destruction of the mucosa and submucosa and everything, loss of blood supply. The ciliary dystrophy, cilia are destroyed completely. So there will be stagnation of the secretions, and then this stagnation result in drying of the nasal because of the excessive air will enter because it is not being humidified. So the dry air will cause drying of the nasal cavity, and then there is a crusting of the things. Wherever there is a stasis is there, the infection sets in. So here, when there is a infection sets in, what will happen? There is a saprophytic organism will grow, and then putrefaction will take place. Wherever there is a putrefaction is there is a very bad smell emanating from the patient. That is a known as ozina. Ozina means the bad smell emanating from the patient is known as ozina. But the person, because of the loss of sense of smell, they will not appreciate that bad smell. That is, otherwise, it is known as merciful anosmia. Merciful anosmia means blessing is disguised to the patient. Even though the patient, the surrounding people are having a very stinchy feeling that very dead fish, what will be there, the putrefying fish or anything, what the smell will be there, very awkward smell will be there. So that stench will be there with the patient, emanating from the patient. But luckily, the patient will never appreciate that. Okay. So symptoms will be the foul smell emanating the patient, crusting will be there, dryness, and then loss of sense of smell, nasal obstruction in spite of very roomy nasal cavity. Nasal obstruction in spite of roomy nasal cavity, bleeding from the nose whenever they try to remove the crust, and then headache. These crusts will obliterate the sinus mucosa, sinus arestia, and then it will be just like any sinusitis or anything. It will be the patient will be have severe headache, and also on examination you can see a crusting. That means you can see a crust will be there, and then turbinates will be very much atrophied, then roominess of the nasal cavity, and then nasopharynx. Up to the nasopharynx, it get atrophied, and then nasal mucosa is pale, shiny, dry, and atrophied. Septal perforation can take place because of the repeated removal of the crust can lead to king, and then destruction of the septal mucosa can result in saddle nose deformity, and then atrophy of the pharyngeal and laryngeal mucosa, and then posterior under posterior endoscopy you can see the crusting and dry mucosa posteriorly. So here, whenever you see anterior endoscopy with the microscope, you can see the crust. You can see the crust within the nasal cavity with a reduced nasal mucosa. And then the complications are sinusitis, ear infections, atrophy pharyngeal, nasal myiasis, and then psychologically problems, because all these things, because all the people will avoid them. Social boycotting will be there because of the stinky smell. So one has to be the person will go into psychological stress. Why? Because unknowingly they will not be knowing that she's emanating that much of bad smell. This is what is meiosis means. Meiosis is nothing but the larvae of the common housefly. Because wherever there is a saprophytic organism, there is a putrefaction is taking place. these flies, because the person with atrophic rhinitis with the crusting and all, they will not know that they will not have any sensation. So what will happen? The housefly, common housefly, go and then lay their eggs there in the nasal cavity. And then they hatch, and then they will be hatched. Then the larvae, the common housefly larvae will be coming, and then they will be boring. The patient will have pouring pain, headache will be there, and then sometimes they may cause erosion of the skull bones. There is the base, skull base, there is bibulous plate. Then the nasal maggots entering the intracranium also is there. So nasal myiasis is also one of the chart notes for you. The nasal myiasis. It is a larvae of the presence of larvae of the common housefly in the nasal cavity, which is commonly seen in atrophic rhinitis patients, also chronic debilitated patients in rhinitis caseosa, and also in cases with the oral myiasis also, ears also, whenever there is a cholecystoma with a chronic diabetics with malignant otitis externa, or uh, the necrotizing otitis externa. These are the things where you can see the nasal myiasis or oral myiasis. So there, whenever there is myiasis is there, one has to give antibiotics, and also you have to repel them by putting a chloroform packs in the nose. By anesthetizing them, you can carefully remove the nasal maggots with a patiently. One has to remove all the things, and then you have to treat the underlying atrophic rhinitis. Then this nasal myiasis also can be eradicated. The psychological problems, one has to assure them with the treatment and everything. If needed, psychological consultation or psychiatric consultation also has to be taken. So what are the various investigations we do? In all the cases of these things, we take it as a rhinosinusitis, and we go for radiology, X-ray of the paranasal sinuses. If you are doubtful, then you can go for CT of the paranasal sinuses. And then complete blood picture. And then one has to see serology for syphilis. And then examination for the dermatological exam for any other chronic granulomatous diseases like leprosy or anything. And then nasal smear for any to identify for culture and sensitivity of the organisms. And then take a biopsy and see whether there is a hypertrophic or atrophic or anything. One has to do biopsy. And then radiograph of the chest to rule out any tuberculosis. So what is the differential diagnosis for all the things is chronic specific rhinitis, rhinitis, rhinoscleroma, rhinolith, foreign body, sinusitis. These are all differential diagnosis for atrophic rhinitis. So whenever you see a chronic specific rhinitis, one has to think of atrophic rhinitis. Like this, these are all the differential diagnosis for atrophic rhinitis. Treatment is, it is medical treatment first. Always underlying treatment before going for treating the underlying cause. First of all, we have to make the patient fit for surgery. In a patient where the crust and everything is there and the myiasis is there, one has to completely treat the myiasis. Then all the surgical procedure has to be taken later on. What is the medical treatment? So here one has to understand none of the medical or surgical treatments give satisfactory results. Complete cure of the disease is not possible in primary atrophic rhinitis. If you know the cause, you remove the cause, then you can see that there is a cure can be achieved. Whereas when you don't know the etiological factors, the treatment is very, very difficult and then unsatisfactory. So one has to treat the patient symptomatically, then there will be a patient for lifelong. See, what is the aim of your medical management? One has to reduce the crust, to prevent the foul smell, and to keep the nasal cavity clean and moist. So one has to go for either systemic drugs as well as the local treatment. First of all, we will go to the local treatment. So nasal irrigation and removing the crust nasal cavity has to be irrigated with the alkaline douches. So every time I'm telling you alkaline douches, two parts of this one. So one part of sodium bicarbonate, one part of sodium bioborate, and then sodium chloride. This is the thing, all the three in 250 milligrams or milliliters of water, and then you have to prepare them and then give a mucosucker, then or a syringe, and then teach them how to douching or the nasal douching, alkaline douches. So two parts of sodium bioborate, two parts of sodium bicarbonate, and then one part of sodium chloride in 250 ml of liters. That is around 24.5 grams. It is 48 grams. So those are the things. And then you have to, in a lukewarm water, and then you have to irrigate, and then gradually after irrigation they will get softened, and then they can be removed. How they can be removed is, there is another method is there, is 25% dextrose, the local drops, 25% dextrose in glycerin. So 25% dextrose in glycerin, how it will act? Glycerin will act as a hygroscopic. That means it will draw all the water into the crust, and then they will become softened. And then dextrose will kill the saprophytic organisms, and then there will be the saprophytic organism will be killed, and then glycerin will act as a softener, and then you can remove the crust. Locally acting antibiotic solutions are available. There is known as chemicin solution. Then local estradiol, that is estrogen drops or sprays are available, or emollients like liquid paraffin or glycerin. White glycerin can also be given locally, and then one has to remove the crust, and then you have to, after that, to increase the blood supply. There usually, previously, local infiltration of placental extracts, they are used to be available. Placentrex injection used to be available. Nowadays it is not coming. Locally you can infiltrate, that inject into the submucosa, so that by increasing that, by injecting, you can increase the local vascularity, and then you can again regain the nasal cilia. This is one of the thing. So sometimes previously in olden days, the placental amniotic membrane has to, they have to sterilize it, and then they use it to implant submucosally there in the nasal cavity. And the anti-drying agent like glycerin, mineral oil, paraffin with 2% menthol has to be given to the nasal. This is the medical along with that, you can give local, that is oral antibiotics. Oral antibiotics is streptomycin, tetracycline, or ciprofloxacin, or any amino glycoside you can give. And then good diet. These are all people coming from low socioeconomic background. One has to give high protein diet with vitamin A, iron, and then local potassium iodide tablets. Potassium iodide oral tablets, they will increase the nasal secretions, and then vasodilators can be given. And then surgical treatment is to reduce the size of the nasal cavity. So how to reduce the size of the nasal cavity? By, there are so many methods are there. One thing is reduce the size of the nasal cavity. Second is the decrease the air entry into the nasal cavity. Third is the to increase the secretion of the nasal mucosa. These are all three types are there. One is reduce the size of the submucosal implantations, Teflon, silastic cartilage, fat into the bone chips. Submucosal injection of placenta, medialization of the lateral wall, Lawton-Slager's operation, that is by submucosal implantation of Teflon or silastic or septal cartilage into the lateral wall. By doing a thing, there is a medialization of the lateral wall, that is Lawton-Slager's operation. So here you implant any silastic or anything, or in the lateral wall also. Here you can reduce the size of the nasal cavity. or it can be done intranasally or sublabially also by elevating the medial and lateral walls, and then you can implant the elastic or any cartilage pieces or synthetic bone to decrease the air entry into the nasal cavity is a Young's operation. Young's up, that is, air entry can be, there is one belief is excessive air entry is causing the nasal crusting and everything. So closure of the nares, complete closure of the nares is known as Young's operation. There is another operation known as modified Young's operation. By leaving a 4 mm aperture, you have to close the anterior nostril. That is a modified Young's operation. So circumference flash elevated 1 centimeter cephalic to the alar rim. Sutures placed in the center of the elevated flap to close the nostril, complete nostril. For 3 months remove, and then after that you have to relieve the things and then see. So people have relieved this symptomatology. Disadvantage: difficult to elevate circumference flap. Breakdown of sample sutures are more common. Does not allow for cleaning. Did not allow for periodic examination. Recurrence after flap takedown. These are all the various disadvantages of Young's operation. So it is a modified Young's operation is there. So here, what is the thing is, you have to complete closure is there. Okay, it is the Young's operation. Here, modified Young's operation means one small 4 mm things will be left alone between the lateral and medial wall. If you completely close, it is a Young's operation. If you leave 4 mm aperture, it is known as modified Young's operation. Easier than Young and procedure, no suture-like breakdown, no vestibular stenosis or takedown. Disadvantage: you can examine with the 4 mm endoscope here. Cleaning cannot be done here also. Periodic examination nowadays with the endoscope, you can do that. Recurrence after flap takedown is one of the days. Here is another thing is stellate ganglion block, cervical sympathectomy. There is a extensive Whitmack's operation, means the parotid duct can be transplanted into the nasal, that is the maxillary sinus, and can give rise to continuous secretions. Then moisturization of the nasal mucosa can be done. And then there is a transfer of maxillary antral mucosa into the nasal cavity. There is a Raghava Saran's operation. These are all the various surgeries advocated, but of not of very much use. So here, another thing is non-surgical methods are taken impressions, and then you can close the nasal mucosa. That is nasal molds. Impressions are used to create elastic obturators. And then it is whenever you want, you can take out and easily remove, and you can examine the nasal cavity. And then serial clinical examination can be done. You can surgical morbidity is very less, but maybe uncomfortable. The patient may not keep them completely, because sore throat due to obligation, mouth breathing. Because whenever you completely close the nose, one has to resort to oral breathing. What will happen? The patient will have drying of the mouth, because that air conditioning system is lost. Then the patient will have a. So we are all obligatory nasal breathers. Otherwise, if you resort to mouth breathing, these are all the very comfortable patient can cause. These are the nasal obturators which are available, elastics obturators. Secondary atrophic rhinitis, usually because of DNS. So on one side there will be narrowing will be there, another side, roomy side, there is every chance of this one you might have heard in your previous class. This is one of the complication of DNS is atrophic rhinitis. And then in chronic specific rhinitis like leprosy, syphilis, lupus, tuberculosis, rhinoscleroma, these are all chronic granulomatous diseases which can destroy the nasal mucosa, nasal cilia. It can result in and mimic this atrophic rhinitis. So if you remove the primary cause, usually the patient will be okay. So what is the other? The recently extensive nasal surgery, complete removal of the lateral wall of the nose. in cases of tumors and everything, or overactive, enthusiastic surgeons remove complete turbinectomies for hypertrophy turbinate. Extensive cauterization services, overcorrection of the DNS, septal perforations, extensive nasal polypectomies, surgery for rhinosporidiosis, removal of nasopharyngeal fibroma where we resort to partial medial maxillectomy, and then chronic. These are all the various things, and also radiotherapy also can cause this secondary atrophic rhinitis. So this will lead to completion of rhinitis. Next, we will go for next class. Somebody will take you to acute and chronic rhinosinusitis. That is sinusitis. Okay. Okay. Have a good day. ఆపేచ్చా? సార్ కూడా రాలేదు కదా, వస్తే చూసాను అందుకని ఎవరు రాలేదు. ఎవరు నెక్స్ట్ 9th ఎక్స్ట్రా. ఓకే, ఇది మాకు ఇవ్వరా, ఇది ఇవ్వరా? అడగాలి నేను మొన్న మాకు ఇక్కడ వరకు రావడం అన్ని ఇదే. రామప్రసాద్ ప్రిన్సిపల్ అడగాలి, ప్రిన్సిపల్ తోటి అడుగుతాను నేను.
సూర్యప్రకాష్
ఆయన రాలేదులేండి. అదే
చాలా మేడమ్స్ కూడా అంటారు, మాకు పాస్వర్డ్ ఇచ్చేస్తే ల్యాప్టాప్ లో చెప్పేసుకుంటాం కదా. ఆ మధ్యన అయితే డేటా ఎంట్రీ వాళ్ళు మంది ఉండేవారు, అప్పుడు ఇంకా ప్రాబ్లం వచ్చింది. ఇప్పుడు 3 days నుంచి వాళ్ళు ఎవరు రాలేదు.